quote with your neighbor. Introduce yourself, read the quote, interpret it. Tell your neighbor what you think it means, and let them tell you what they think it means. Identical. Maybe one? How many of you are pretty close to each other? Okay, how many of you are very different? Alright. So, of the 7 of you that are participating, I want to hear some examples. So here's some examples. The quote, if you can't read it, the quote says, give a man a fish, feed his family for a day, teach a man to fish, feed his family for a lifetime.
So, my son Alexis is kind of taught me something along these lines. You can give a man a fact, like some bit of knowledge, and he'll know that. But then you tell him, you teach him how to learn. And that's just way more valuable because you're going to learn for the rest of your life.
So if you give an individual a fact, they can learn that fact. But if you teach them how to learn, then they can apply the learning process all throughout their life. Okay, I like that.
Mine was more of a real life application. My dad wanted me to help him with his electronics. So instead of just turning it on for him, I showed him how to do it. So
That's smart. So instead of just saying push the on button, you actually push the on button and have him do it with his finger. Yeah, it's amazing how that works for our folks, huh? Oh, you mean the on button. That's what you were talking about. Yes, yeah, the on button. Okay. Anything else? There's 5 more of you that voted. I know it. I saw the hands. And there's like 103 more of you that aren't playing. Yes?
I think it's just demonstrating the importance of not enabling people and giving things to them, but rather teaching them how to find solutions.
Okay, so not enabling somebody, but maybe teaching them how to find a solution to help themselves. Okay, I like that. So here was one that a kindergarten teacher told my wife and I. And said, you know, we're really focused on teaching children how to read. Because from that point forward, if they become good readers, then they're going to read to learn. So once they learn to read, then they read to learn. And so it is a skill set, like fishing. So there's 2 reasons that I explain this, use this example. Number 1 is, I'm not satisfied with my job if I just train you on how to spit out the correct answer. I want to help educate you or teach you how to actually analyze and come up with the answer. answer or the solution, okay, or how to learn yourself. Number one is you'll actually retain the information much longer. You'll apply it to things way beyond this class. This is not all there is to life, general pathology. And you're going to move on and you'll use those skill sets in your next educational career path. And so that's my desire as a teacher, is in order to do that. Second reason I use the example is there were some interesting themes that were probably more similar, but those were not identical. The on button on a remote, okay? Rather than just giving facts how to learn, a little bit more of a philosophical answer, which is exactly correct. All of them are right, but they're all unique and different. So all of you, as you pair up and you do study partners, that's one of the values, is your study partner can help you look at something from a slightly different perspective, and that's actually really important. Okay? For Hannah and for Kyle, when they're working together as professionals, they're going to need to listen to each other. Is one superior to the other as far as their influence or their knowledge, or if they're right or wrong? Now, there may be a hierarchy in the job place because somebody's a boss and someone's a subordinate, but every person on the team, their opinion is actually critical because it might be a different way of looking at it. Because you can't immediately say, well, you know, you're my subordinate, so you must be dumb. I mean, you're not going to go very far as a boss if that's the way you run your clinic, right? So understanding, embracing that there's going to be different interpretations to this, just like we're going to see different interpretations to things throughout the semester is really important. So we talked about the course syllabus at length, so I don't think we really need to belabor that any longer. Again, it's on the PB Learn shell. We're going to track with it pretty well. Pre-quizzes, post-quizzes, be in communication. You've got contact information for Kelsey here, but it's also on the syllabus. Okay, it's on the syllabus, and my contact information is there as well. So, anything else before we get started? I can't reiterate enough the importance, this is my little reminder, meeting with you, to form study groups. Do it early. Help sharpen each other. There's another proverb that says, as iron sharpens iron, so one man sharpens another. Kind of cool, huh? And it's mankind. I mean, it's not like, oh, well, I'm a woman, so I guess I can't sharpen anything. That's not what it meant. It's mankind, okay? So, together is good, right? A cord of 3 strands is not easily broken. You've heard that. There's strength in numbers. So if you work together, you're going to be better as a result of it. Okay? Keller said we can't work guy and girl together. It's only man, and no, that's not what I said. Okay? Just partner up with people and work together. All right, so a little bit about me. I'm going to give you a little bit of background, and then we're going to dive into our lecture. So I did my training at the University of Arizona, and I did all my education there. I did my bachelor's, my master's, and my Ph.D. I'm a physiologist by training, and then when I went into the workplace, I basically became a biomedical engineer. I left university and I went into industry. I worked in industry for about a decade, and then I came back to academics and started teaching. We went from Tucson to San Diego, lived in San Diego for a little while, didn't have any kids. It was pretty fun. And then we started having kids. We were from Arizona, so we wanted to come back. I worked in biotech in San Diego, and then I got recruited by Gore to come work in Flagstaff. Gore's a medical device company. I was working there for about 5 years, and then I left there to come to NAU and start teaching. I started teaching part-time, and I was working back with startup companies in San Diego, and I kind of gave that up and did this full-time. I want to be here. I teach because I like teaching. My appointment as a full-time faculty member is a teaching appointment. So there is not a research component to my appointment. So I came to the university to teach. That's my passion. I still do a lot of research, but my lab is off campus. It's a private lab. We have undergrads, we have graduate students that work there, and Ph.D. level scientists. And we do a lot of work within wound healing, cardiovascular medicine. We do a lot of work with stem cells, a lot of tissue culture. And so I feel like I'm blessed to be able to do what I do because I really enjoy it. And it's a lot of fun. So I hope that when I show up on Tuesdays to lecture, you can feel that enthusiasm because it's something that I'm really passionate about. I wouldn't be doing it if I didn't like it. Okay? My wife and I have 4 kids. Their ages range from 5, 8, 10, and 12. And they're all girls. And my poor boy dog, even he's like a girl. I've tried to show him how to, play, but he just looks at me weird like. So it's a fun house, and that's a little bit of the personal background about me. So let's move on in the lecture. I want you guys to partner up and maybe turn to the other direction. Maybe find a new partner. Next week, some of you are like, I am not sitting here next week. Just kidding. One of you defined pathology, and the other one defined epidemiology. Partner up with 3 if you need to. More floors. Explanations or definitions on pathology. What is it? The study of the cause of diseases. Close. Actually, it's not cause, just study of diseases. Okay? But that's actually really good. You just be going above and beyond if you study the cause. You just study the disease, but yeah, that's gross. That's pathology. Okay? Anything else? Any other explanations? The study of disease. The disease state. Okay, maybe aspects about the disease. Anything else?
Study of tissues commonly affected with disease.
Study of tissues that might be affected with disease. Okay, like that. Let's unpack the effects. How would that translate to your future life as a professional? What would we call that?
Symptoms.
What's that? Symptoms. Or another fancy way of saying is the clinical sequelae. Can you spell that? No. I suck at spelling. Google it. It's like S-E-quella. My daughter did win the spelling bee last week after school. I was so proud. And I helped her study, and my dad found out about it and called me, and he just started laughing. I'm dead serious. I'm like, yeah, but you know what the on button is? Now he's like, you helped her study? You're like the worst speller. I'm like, I know. The things I do for my kids. I was like on my phone the whole time. I was like, what was one of the words that I totally butchered it. Oh, like Noceum. I think I pronounced like Nokium. Like Nokium. It's like, Dad, that's not how you say it. Like, oh yeah, you're right. Like, who was quizzing who? What was I talking about? Oh, pathology. Okay. I get a little sidetracked. Pathology, study of clinical aspects or clinical sequelae or symptoms. That's what you said. It literally translates is the study of suffering. Okay? That's what you guys are into this semester. Okay? That's the actual translation from the Latin, the study of suffering. How about epidemiology? Let's switch over to B. Person B.
Study of disease in populations.
The study of diseases in populations. I like that. Anything else?
The study of how disease spreads and how to control it.
The study how disease spreads and maybe how to control it or how to prevent it from becoming widespread. Anything else? Both those are really good. Study of illness in a population. Like the Ebola virus. Remember that from a few weeks back to a couple months back? You might have been glued to the television screen kind of figuring out, I'm not flying to Texas anytime soon. Right? So you like rerouted your flight around. You were an epidemiologist. You were anticipating where that disease was going to go and you were avoiding it. Okay? All right, next up, I want you to write down 5 of your favorite diseases. I know you guys are weird like that. You got favorites. You're like, oh yeah. 5 of your favorite diseases. You don't have to have any of them. It's not a requirement. But oftentimes you pick something maybe that a family member has. You know, it's in the family. Heart disease, huh? Well, you're most interested in it, right? Favorite synonym would be most interesting to you. All right, getting serious now. What are some examples? Just shout them out.
Meningitis.
Meningitis. We'll cover that one. Diabetes. We'll cover that one. Which one? Type 2. We'll cover that one. Type 1? Oh, yeah. Very good. We'll cover that too. Insipidus? Oh, yeah. We'll cover that too. What else? Sarcoidosis. We won't cover that one. Alzheimer's. We'll cover that one.
HPV.
HPV. We won't cover that one.
Herpes.
Herpes. We won't cover that one. Crohn's. We'll get into that one.
TB.
Tuberculosis. Yeah, we'll get there.
Lupus?
Lupus. Yep, we'll get there.
Fibromyalgia.
Fibromyalgia. No, that one's a pretty interesting one. We won't get that one. We won't get there. What else? Huh?
MS.
MS. We'll get there.
Gout.
Gout. No, we won't get there. Oh, ALS. Yeah, we'll get there. Rheumatoid arthritis. We'll get there.
COPD.
AIDS. We'll get there. COPD. We'll get there. Malaria. No, we won't get there. There's a pill for that, by the way. Huntington's. We'll get there. Atherosclerosis. We'll get there. You have to wait to the very end. Parkinson's. Yep.
I don't know the name, but it's a disease where you know who the person is, but you can't recognize the face.
Yeah, it's happening right now. I totally know you, but I don't know your name. What was your name? Troy. Okay. I'll have to remember that. Otherwise, I might have that. We won't get there. Okay. What other ones? Well, we're going to cover a lot of your favorites. Favorites meaning like the ones you're most interested in. Maybe it's because it's in the family. There's a family member that suffers from type 2 diabetes, or MS, or atherosclerosis, okay, or COPD. It's not uncommon that you move into a field because of a personal influence, right? Maybe a family member has suffered with this disease for your entire life, and so now all of a sudden you're like, I want to do something worthwhile in my life. I know an awful lot about how to take care of this person. I would like to understand how the disease works. And I would really like to know how I could actually contribute. Well, the exercise is supposed to go a little bit more like way more of you come up with diseases that we don't cover than what we are going to cover. But we're just on the same page. So we're going to cover a lot, but we're not going to get to everything. This is a general pathology class. So if there's something like gout that we didn't get to, or fibromyalgia, you know, it's not because we don't think it's interesting. It's just we just don't have enough time to cover them all. The goal here is to give you a broad base of exposure from which you can move on. Okay? And if you can understand a lot of the mechanistic processes of how these things work, the causation of the disease, beyond just what is the disease and what's its effect, how did it start mechanistically, you can apply a lot of those things to the next set of diseases that you investigate. All right, now you don't have to switch, but maybe compare with your partner and work together and try to write down and identify the primary organ system that your disease on your list affects. Like COPD would be the lungs. Okay? If it's a multiple organ process, nobody said the flu, which I thought was interesting. Okay? You could say the whole body or multiple systems. So, what sometimes is interesting and a good place to start is when you're thinking about a disease, and this is how the format of the class will be. We oftentimes will identify the normal physiological system. And I might rattle your brain a little bit about 201, 202 when we talked about how it normally is set up or how it normally works. It's always really good to have a control to compare it to. So we're talking about atherosclerosis, which is hardening of the blood vessels. Okay, all of them, actually. But the smaller ones, it tends to really hit aggressively. Or you have more clinical effects or sequelae or symptoms because the smaller the lumen, and the disease has a greater effect because it narrows the vessel more quickly. But you have those lesions in the large vessels too, like the aorta. But the blood flows so fast that even though it's narrowing, instead of 100% open at 75%, it's such a large tube. By the time you're 70 years of age, it's about 40 millimeters in diameter. That's 4 centimeters. Okay? That's just shy of 2 inches, for those of you that are metrically challenged. So the aorta, interesting, it dilates as we get older. Okay, so it gets bigger as we get older. So do your earlobes and your nose hairs, but that's a different topic. So in atherosclerosis, the clinical sequela affects all the vessels, but it's important for us to understand, okay, what's going wrong in atherosclerosis and what does the lesion look like in comparison to what it's supposed to look like. So we get to the end of the semester when we cover cardiovascular, I'm going to show you plaques and vessels, and it doesn't really register unless you see what the normal looks like. We're going to come up with an example here in just a moment. So a tool that will be helpful and valuable this semester is identifying what the normal tissue looks like. You can pull out your old 201 and 202 textbook. You're like, really? Yeah, I mean, those are valuable resources. You'll say, well, why would I keep them? I mean, they're like new editions every year. And I decided not. You should keep your textbooks. I mean, the human body has been essentially the same for thousands of years. Okay? It has not evolved at all from the 8th edition to the 9th edition, I promise. Okay? Same structures. There's not 3 arms now, 4 hearts. Okay? So your textbook from 201 and 202 could be a valuable resource for you in this class. Because you're going to have to go back to nephral sclerosis when you have scarring of the kidneys. You say, well, what does the kidney normally look like? You could go to the DVD and it's there, but then you have to buy something else. So use the stuff you already have. Okay? So that's an activity to help us set up for aspects of how we're going to look at this class. So as we talk about in the last 20 minutes today, or 17 minutes, what is pathology? We have 4 main aspects. We've got the etiology. That's the study of the causation, as was brought up. So the causation or the etiology of the disease. How did it start? Where is its origination? The word etiology is a Greek word that actually means and translates giving a reason for. Etiology is giving a reason for. So that is the cause of the disease. The pathogenesis, right, that's Greek pathos is disease, and genesis is creation. So that's the disease creation. Well, how's that different than the causation? The causation is what triggered it. The pathogenesis is the mechanism by which the disease was propagated. So is it acute or is it chronic? Is it short-term or is it long-term? Thirdly, we have morphological changes and morphological alterations. Those can happen at the macro. We use the word gross. Some of you are taking, or some of you will take, the gross anatomy course that we offer at this institution, which is a fantastic course. And Dr. Abel does an incredible job with it. It's pretty unusual you can take a class like that at a undergraduate level. Okay? Just so you know. But again, if you don't have a reference point to know that, then you just say, oh yeah, all schools have it. Not necessarily. But gross anatomy is at the macro view. Where are things, right? What are the morphological or the structural changes? That's what that word means. Morphology is structure. What are the gross or large-scale macro structural changes that happen with nephrosclerosis? Well, you actually get a hardening of the outside of the kidney in this example. Well, what about the microscopic changes? Well, the microscopic change, you have to get under the microscope to look. And so if you remember back to the urinary section, if you looked at the architecture of the nephron, you have a glomerulus, you have the tubular network, okay? Well, when it becomes scarred or infarcted or damaged because of lack of blood flow or because of toxins, then that tissue is replaced with scar tissue. It's a collagen-like extracellular matrix scar, which is not much different than if you had a cut and then you have a scar later on that filled in the wound gap. That is scar fibrotic tissue that goes in and fills the void space. That happens in the skin. We see it. It happens in the kidney. It happens on the heart. It happens in the brain. It happens in the pancreas. It happens in any tissue, scarring. So nephrosclerosis or scarring is just a fancy word that says there is a wound in the kidney, and how does it change? Well, that glomerulus is gone, and now you actually are replacing it with scar tissue, kind of like you see a cut on your skin. So you have microscopic changes. And then lastly, an aspect, so 4 aspects: etiology, pathogenesis, morphological changes that are both gross and microscopic, and then lastly, what's the clinical who cares? What's the clinical significance? So in this class, we're going to see all 4 of these aspects as we get through all of these diseases. Sometimes we'll really emphasize one more than another aspect. But another study tip is, as you're thinking about a disease, maybe ask yourself these questions. What are these 4 aspects for ALS? What are the 4 aspects for rheumatoid arthritis? Right? Rheumatoid arthritis. One of my favorites on this list, it's hard. My favorite is probably, I like the clinical significance a lot because I'm a very applied person. I want to know, like, what's the impact? What's the who cares? And I also like to understand, like, what happens to cause it. So the bookends are probably my favorites, or the ones I'm most interested in. But you should really ask yourself all 4 of these questions as you move through. So let's talk about a first example of a disease. We're going to get into this. This is a disease example. It's called Barrett Esophagus. So what's the organ system? Esophagus is part of what? The digestive system, GI tract, gastrointestinal system. Okay? It just puts it in a frame of reference. And you're like, oh, I need to go back to 202 and look through the digestive chapter and just remind myself of what the esophagus looks like. That wouldn't be a bad idea if you're really foggy on it. Okay? So we've got 4 aspects of the disease. And these 4 aspects of the disease, I'm going to write down. So number 1 is these patients suffer from gastroesophageal reflux disease. We have a lot of nomenclature. We abbreviate this GERD. GERD, gastroesophageal reflux disease. Number 2, approximately 10% of these patients develop Barrett. So what's the cause? What can you ascertain is a problem right from the beginning? Acid in the esophagus. Okay? Number 3 is prolonged injury. So patients who have GERD chronically, chronic GERD, you may know somebody that suffers from this. This is gastroesophageal reflux disease. Is a fancy way of saying heartburn. After they eat pizza, they have heartburn. You know, they take a couple of Tums, and it happens every night. Spaghetti. Actually, it doesn't really matter.
Why is 10% considered significant? Isn't that relatively small?
Well, so I'm going to show you Barrett, and the other 90% have abnormal esophageal lining, but it's not at the level of Barrett quite yet. So that other 90% that doesn't develop, it probably will if it goes on, untreated. The last thing is we have what we call cellular metaplasia. cellular metaplasia is from the Greek. It means a change in form. Metaplasia means like metamorphosis, right? Changing form. So the cells that line the esophagus alter in their phenotype to become more like the cells that line the stomach in patients with Barrett esophagus, because that acid reflux is bringing up hydrogen chloride into the esophagus, and so the cells become goblet-like cells. So, the etiology, chronic GERD, about 10% of the patients with GERD develop Barrett, as we said. Patients appear to have more massive reflux with more and longer reflux episodes once it develops into Barrett. 10% develop it. We don't really understand why is it just 10%, to your point. Why is it, what happens to the other 90%? Most of the research suggests that it's just a matter of time before they're going to develop it as well. Okay, but it is a risk factor. GERD is a risk factor for developing Barrett. So what does Barrett look like? I'm going to show you some macro and micro architectural changes that have happened, but I have to show you the control too, right? So you understand what does it look like. So it's a risk factor. What's the clinical significance, right? This is the, who cares? Well, it's a risk factor for an esophageal adenocarcinoma. Ooh, that sounds bad. These are really expensive terms that I'm throwing at you, like $50 words, so you feel like you're getting your money's worth today. Okay? Esophageal adenocarcinoma. Carcinoma. Please use it in a sentence. Esophageal adenocarcinoma. So what happens is, what's the normal epithelium of the esophagus? Do you guys remember? Stratified what? Squamous. Squamous. Either way you want to say it. Right? It's an epithelial interface that has food coming down it, so it's subject to abrasion, and that's why stratified squamous or stratified squamous epithelium is used. That's why we have it in our skin. That's why it lines the cheeks in our oral cavity. Okay, so we're chewing our food, we put it down the esophagus, and it abrasively goes down the tube, but it's protected by the stratified squamous. Well, it is replaced because of cellular metaplasia with columnar epithelium, which is what happens in the stomach. That's what you see in the stomach. And that columnar epithelium is as a result of this cellular metaplasia. So you have an alteration of the stem cells in that epithelium, and they differentiate into something different. They turn, instead of the basali layer giving rise to new stratum squamous epithelium, it actually becomes columnar in phenotype. So just a quick review. What are the different types of stem cells? You guys remember? Well, number one, you can have adult. You can have embryonic sources. Right? And now we have what we call induced pluripotent. That's where you take an adult cell and you kind of convert it backwards to behave more like an embryonic cell. So adult, embryonic, and induced pluripotent. Induced pluripotent, we abbreviate IPS. So the ones that we're talking about right now are the adult type. That's the type that you and I have that every 6 to 8 weeks gives us new skin and gives us a new lining of our esophagus. Well, if we're chronically irritating it with acid, then that basali layer, that adult stem layer says, I'm not going to just make a squamous epithelium, I'm going to make a columnar epithelium, and I'm actually going to make goblet cells so I can release this protective mucus that covers the surface. Pretty crazy, huh? So, let's take a look at the gross macro view. Normal is on your left. You're like, really? I thought that was the bad one. Look at all those white splotchy things. Yeah, that's what the esophagus normally looks like because it's stratified squamous. Okay, that's the normal epithelium. It's moisturized, it's a slippery surface, so the food kind of just goes right down. Normal's on the left. On the right image, you see less of that white glistening surface, and you see more of a red colored surface that's indicative of the columnar epithelium. If we look at a lesion that has progressed to an esophageal adenocarcinoma, so it's going to go in this picture on the left to the picture on the right with Barrett esophagus. This would be Barrett esophagus here. Then the next picture down is the progression of Barrett esophagus, developing a benign, which would be considered precancer, esophageal adenocarcinoma. You can remove it. Typically, it'll be fine. We'll talk in the cancer lecture more about the different types of nomenclature. If we look at the histology, the microarchitecture now, you can see in green, green means good, right? Green means go. Here is stratified squamous or squamous epithelium. And over here, which is not that far away, is this metaplastic columnar. You see this goblet cell? There's one right there, there's one right there, and there's like 1, 2, 3, 4, 5. You see all of them right here? So we've moved, and this is still in the esophagus. So microscopically, you would expect it to look like this, but now we're seeing, here's actually goblet cells here. I just pointed over here, but they're actually as close as here and as here as well, and even right here, but they're more obvious right here, I thought. So you get this phenotypic alteration, this metaplasia, in these patients. If we look at the clinical features, typically they're 40 to 60-year-old males. Okay? White males are the highest risk category. It's a localized alteration as it begins, and if it's greater than 3 centimeters of Barrett mucosa, which is the mucosa I just showed you in that previous histology slide, then it's 30 to 40 times at higher risk for this esophageal adenocarcinoma. Doesn't mean you're going to get it. It just means your risk factor goes up by 30 to 40-fold. And if it advances into what we call a dysplasia, dysplasia means it goes to an abnormal cellular architecture, then it becomes cancerous. So the stages would be GERD, and then what would be worse than that would be Barrett. What would be worse than that would be the esophageal adenocarcinoma, and then you would have esophageal cancer. This happens in other systems as we wrap up today. If you look here, this is an ulcer that's in the stomach duodenum, and you can see that's the normal histology on the left. These are all taken off the histology DVD. You see these Peyer's patches, which are part of the immune system because you're in contact with a lot of outside agents. And if you have an ulcer on the right, you can see you've got breakdown of this border. The border's gone, and it's replaced. You lose your Peyer's patches, and all of these purple dots are all inflammatory cells. So in an ulcer in the stomach or in the small intestine, you also see this metaplasia that takes place, just like you saw in the esophagus. Questions so far? Okay. Next week, we're going to launch into cell injury and cell death.